Think of what we share in agreement, in contrast to others. We really put an emphasis on one therapist working alone, I think. We put an emphasis on changing people within the interview as well as with directives afterwards. Mm-hmm. We don't assume that if people understand their problems and why they have them, they'll change. We assume it's our obligation to change people, that we're not neutral observers of their plight. So the difference, too, that I think that we share, and that is, I think therapy has to be, even though you can teach some standard procedures, you really have to innovate a procedure for each case, because every family is different and every person is different. And we've always done it that way in contrast to making a method which is supposed to make everybody fit into that method. Now, there's one thing we ought to get to that I think, one of the differences we have, maybe, is I think I tend to focus much more on the symptom than you focus.
Absolutely, yes.
And you prefer more a different focus, except if you have a life-threatening symptom, like a kid starving with anorexia. You absolutely focus on the symptom and reorganize the family around the symptom.
Yeah.
I tend to do that with all symptoms, and that's one of our differences, I think.
I think that, I see different points of entry that a variety of schools of family therapy have that nonetheless move in the same direction, in the sense that I think that you focus on the symptom and enter to look at the symptom and the way in which the family organizes it's around the symptom as really the symptom as a metaphor, the symptom as communication, and so on and so forth. And from there, in some way or other, you go to disrupt the family organization to create some kind of changes. And then I see myself as entering and being concerned through the observation of process, dance, whatever metaphor you want. I begin to see the particular way in which people are in proximity, distance, the kind of coalitions that they have. And then I enter through that particular avenue. There are different ways of entry. I don't think that they are really different epistemologies. I think that they are preferential ways of disrupting the system. I think that we all move in the direction of perturbing the system, producing crisis, and then a rearrangement that I tend to follow a little bit longer than you.
One of the issues that we used to perhaps differ on, I'm not sure we do now, is on the issue of termination. I think you used to continue with people longer. I would get a change started and then get out so that it would continue. You would tend to make sure the change continued or push with them longer or take further steps, I think.
Yeah.
I don't know whether you still do that or not.
Yeah, I think so. I think that my sense is that I like to buttress the beginning changes.
It's one of the supervisory tasks I think of, is to help a therapist get separated from a family. Because if they get together with a family and they get a change and it's positive, they can always find something else wrong with the family they should work on.
Uh-huh.
The family enjoys them and wants to continue, when really they don't need to continue. And we tend to begin at that point to recess, 2 weeks, 3 weeks, a month, 2 months, in order to separate the therapist.
You see, I learned the recess idea that you introduced as an early device is useful, and I do use that. But nonetheless, I think that I do carry the family longer, and I carry that general practitioner model very much as an important part of the development of a practice.
We do that too in the sense of having them checked up on or called or encouraging them to call. So there's a follow-up with them. But what I'm thinking of is, suppose you have a student who gets very involved with the family. How do you help them separate?
Oh, I think that the idea of give a task and recess and come in a month is the best way of doing it. And then give another task, and you produce.
The student gets interested.
You extend the recess.
Sure. The student gets interested in other families. The families get interested in other things.
No.
But I just thought you might have other means, because it is a problem.
No. I got that from you, and I think that this is a very useful way of doing it. No.
One of the things I've noticed recently is sometimes a trainee who wants to continue to associate with me will keep a family coming in order to continue the relationship with me as supervisor.
Mm-hmm.
Because if the family was cured, we wouldn't have that reason for associating. And that can become, it's interesting when you try to explain why a case goes on, how many aspects of it you can find that keep it going.
Well, there are some relationships with patients that are just pleasurable.
Sure.
You know, and one wants to keep it, but the question is that then the contract is unethical.
That's right. And it's not only unethical, there's another difference that I think we might share. And the other, with each other in the field, is different. I tend to think of therapy as for handicapped people who have a problem. That is, there is a theory that therapy is good for everybody. Everybody should have therapy. It's a growing experience and so on. I tend to think of it as only for somebody who has a problem, and I think there's a stigma attached to it. There's also the fact that if you go on seeing somebody in therapy, you're saying they're incompetent as far as carrying on without therapy. The very act of seeing them tends to define them as a patient. And therefore, I terminate as quickly as possible on that basis, because that gives them the freedom to be people who don't need help. Whereas if you have a theory that therapy is good for people, you see them for years because they continue to improve, grow, and so on.
Well, I tell you where I think that there is a group of people that I would like to see. I would like that they should have some therapeutic contact, short therapeutic contact. That is the people that are in transitional crisis. You know, that I have a very different way of working with.
In your new book, the way you're defining it is not pathological but transitional. Sure.
Yeah, and I think that it is a protective thing to me. That if you have people that are periods of divorce, periods of remarriage, death, the changes from being 4 to being 3 or whatever it is, that at this period there is confusion, trial and error that is not pathologic, and that an intervention of a therapist that is a coach that says, listen, this is normal, these trials are correct, let me help you in the continuous exploration of trials. It is a kind of an educational, supportive, very different than change. I operate, and that's one of the things that I teach my students, by the way, the difference between a therapy that is oriented to change and the therapy that is, in which the therapist enters as a coach in normal transitional periods.
No, I've done that and said, let's not call this therapy, let's just call this a consultation, because you obviously don't need it. So you give it a different name in order to make it normal. And then they also don't have to say to people they're in therapy. They're just going through a consultation.
You know, that was what Bowen said when he was using the term coach instead of therapist. He very early wanted to detoxify the field. And
but there's a difference between doing a consultation with people in the transitional phase when they aren't really into serious problems and doing therapy with people who are in serious problems.
Of course.
So that, I mean, there are people who would tend to call that a systems consultation too, and I don't think that's a good term for it.
You mean
when they are in difficulty.
When they are difficult.
There are people who can combine a symptom orientation with a greater understanding of the nature of the situation. Chloe likes to do that. And she focuses on the symptom, but she also focuses on the whole situation in a way that some people prefer. I tend to think in terms of getting cooperation from a family. That if you're interested in what they're interested in, when they come in with a problem, if you say to them, well, really, that isn't the main problem, there's other issues, they begin to lose their enthusiasm. If you agree with them, that's the problem. Then you begin to get more and more cooperation, and you can get more and more changes and more directives followed. But I think that, there was an old tradition that many ideas came from individual therapy into family therapy without consideration of whether they're relevant or not. Like, I think the idea of personal analysis or personal therapy was carried into the family field absolutely thoughtlessly, with no evidence whatever that it made a better therapist. I think the idea that a symptom has a cause in the psychodynamic structure and the family structure, I think that was carried from individual therapy into family therapy, that the real issue the symptom is just a manifestation, not a cause. When you think of the symptom as a cause, you then begin to see the whole situation differently. And I find that you can get a lot of changes by dealing with what the family thinks is the cause of the difficulty. And in the process, other issues come out and get resolved.
Okay, you see, but this is, what you said, it's true, but partial. And that's one of the things that I am looking today, and the fact that each one of us has a preference, and then we call it the truth instead of a partial truth. I think that, for instance, what you said about if you are interested in what the family is interested, you will get the collaboration of the family and so on. Absolutely correct. I take the family comes with a symptom. We see in the first session this contract, this symptom will be tied to the way in which the family is organized around the symptom, and the symptom then becomes a different symptom, still connected to supporting the deviancy or whatever it is, and the contract then changes. We still are operating in terms of the family and me agree in working in the thing that the family experience as painful. Very similar, but what the family experience as painful tend to be more complexly observed than the symptom itself. So that one can say the way in which the family accommodates to the symptom, positions itself in relation to the symptom, is the symptom, or, so that I think that this is one of the things that I'm trying to sell today to the field, is the idea that we all are partially correct.
That's a philosopher's position, really.
Yes, well, why not?
But I wonder if... I was trying to think of a symptom, besides anorexia, that we would both agree that you should keep the focus on. And it's suppose you get a refusal to go to school. A kid is 12 or 13 years old, staying home, and he won't go to school. Now, would you start with that as the issue and how to get him to school? Or would you start with a more general approach to the family on the assumption that later he'll go to school?
But you see, I really don't have it an either-or kind of thing, because even in an anorectic, I enter with and focus on the anorectic, but very, very fast I move them to the parents to be concerned with the fact that the anorectic girl is disobedient, and I develop some issues some transactions in which the girl will begin to eat because the anorexia is the focus. It is, I work very much never forgetting the symptom, but beginning to create avenues in which the symptom disappears. In some way it's very funny because I am now talking in ways that you were talking before. You know, so that...
And it would be interesting to tease out a difference if there is one.
Yeah. You see, I would say that a family comes in which a child isn't going to school. And then during this session, we can become involved in the fact that how is that your mother keeps you so young? And you are really, you need to be concerned about the fact that you are such an obedient fellow while other people are more. And the object will be that the kid and the mother will begin to be concerned for distancing from each other. And one of the things then that the refusal to go to school can become dystonic. Something that before was experienced as something that gave him power is experienced as one of the manifestations of being dependent from mother and so on and so forth. So
you redefine it.
I redefine, yes.
And then inspire him to go to school to prove something to you. Really.
Yeah. And so that the symptom becomes not going to school, but his dependency on mother. And why is he so stupid that he is cutting his life to obey mother? Some definition of that.
I think often I would work by changing the symptom to a different symptom, by redefining it, and then having them deal with that symptom. But it's just that I tend these days, if a kid is refusing to go to school, to start organizing the family immediately to get him to school the next day. Now, in the process of planning to get him to school the next day, all the issues in the family where he's involved come out.
Absolutely. And this is why I am talking about the point of entry. Because I think that regardless, if you're an effective therapist, and if you enter through that way, you will need to deal with the family organization, and you will achieve a change of the family worldview. And I think that the same thing happened. You see, we are describing here two cases in which I enter and looking at the symptom, redefine the symptom as something that is in the organization of the family. I very much, I think that I teach these people that this symptom is controlled by other people, and that becomes then the way of dealing with the symptom.
But do you assume that if they understand that, it will change?
No, I create tension. I create tension. I said to the kid, you know, it's very interesting, you're rather stupid. You know, here you are thinking you're a big he-man and you are just doing your mother's bid. If you want to do your mother's bid, do it, but you're screwing your life. And I create a situation in which there is a beginning of looking at each other in ways that is very different.
But what I'm trying to understand is the looking at each other differently the cause of change, in your view? I mean, what if you didn't have them look at each other? Would they then not change?
Oh, see, you said that you start from the symptom and then through that they begin to look at other things. I am saying I take the symptom and I change it. This is not that you don't want to go to school, but look at the particular way in which your mother keeps you at home.
But is that to help them realize that, or is that for you to relabel it in a way that it's unacceptable to them?
What happened then is that I create, and I am very good at that, I create a situation in which these two people need to begin, not need to, begin to function with tension between them. The position of supporting that the parents have of the sick child becomes one in which they feel exploited by each other, that they feel dissatisfied with each other. There is a kind of lack of response to feedback and an increase of tension between them, in which I am very much a participant. I join with the kid, I introduce to the kid some idea that in order to satisfy me, he will need to disobey certain of the rules in the family. I enter into the family introducing a different type of relating with each other. I don't think that the understanding is what I am looking for. What I am looking for, what I achieve, for the most part, is a change in behavior. But I don't, you see, then, let's say that the child then goes to school. I would not consider that an end or a successful transaction. My intervention will be oriented to change the symptom, but the changing of the symptom will not be considered for me, and
What would be?
well, I will.
I mean, how do you know when you're successful?
My goodness, that is just too generic and.
Well, I mean, if you were reporting outcome and a certain percentage of successful cases, what would you consider should go on the list as a successful outcome? If you don't count the kid going back to school as a successful outcome.
Yeah, I think that it would have to do with family organization. I think that it would have to do with some follow-up in which there is a change in the relationship between husband and wife, a change in the relationship between son and father. The symptom per se, the change of the symptom per se will not be for me. And
you don't assume that the change in the symptom is an indicator of that change in the family.
I don't think that necessarily is, no.
But there's times when I think you need to focus absolutely on the symptom, and at other times you shouldn't even mention the symptom. I mean, you have to have the flexibility to have a variety of approaches.
Yeah.
But I think that it is possible to change a symptom without changing the organizational structure of the family. But I think more typically, if you organize the family to change the symptom, you reorganize the family. If you organize the family to get the kid to school,
that's correct also.
then they have got to have a different way of relating to each other. And the moment the kid goes to school successfully, they have accomplished that change.
But you see, Jay, what I think had happened to me, I think it happened to many of us, even to you, is that in the measure in which we are in this field a long time, then we begin to lose the absolute certainty that there is one way of doing it. And one begins to...
That would be tedious.
Yeah, well, but, you know, so I begin to teach also to people, listen, Jay does it like that, and Carl does it like that. And in my teaching, there is a tremendous amount of presenting the people that I consider competent changers. They do it in a particular way, saying, what I teach to people is to hear voices. You know, I said, I do hear voices. Carl would say in that situation, and I would do a pretty good imitation of what Carl would say, you know, and And I teach these voices, the voices of the people that I think are successful in the field. I teach Mara's voices. I said Peggy Pap, in working with couples, does that kind of intervention that I think it's an interesting intervention.
Like, you can, I think, once you're an experienced therapist, choose among various voices and try out different things. The problem when you're training is that a therapist trainee who takes a little of that one and a little of this one and a little of that one ends up with mush usually.
No.
But I think they have to have a clear approach, and then after they learn that, they tend to develop.
Well, but I think that it is part of the clear approach that one says, okay, there are some things that we want to produce. We want to produce a crisis in this family. There are some things that I want to produce. You want to produce a change. You need to enter through change. You need to enter through the understanding that people's behaviors are controlled by other people, whatever it is. And then I teach some of the ways in which I do. And then I said, you know, I collect, within this framework, I collect people's voices. And so that if you have a family in which there is a woman that is bulimic, then the idea, I hear Chloe's voice saying, do go to the supermarket, buy junk food, put it in a blender, and so on. And this is a voice that does not necessarily need to fit this family, but I explore that particular area. So that I had introduced in my teaching a kind of curiosity for other people's way of doing it, and at the same time the idea that, that there are some generics that are important, and there are some techniques that one can accumulate that belong to other people.
You know what's happening with us is we're reversing our positions. I remember when I first met you, I was a therapist watcher and researcher on therapy. And I went around the country recording and sitting down, talking to people about why they were doing therapy and how they were doing therapy and why they did that. And I was in a position where if somebody says, this is the way to do it, I would say, well, there's also this way to do it. And this guy over here does it this way. There's a lot of ways to do it. As I got out of the research aspect of this and into teaching, I had to abandon that and say, this is the way to do it, by George. Never mind all those other ways. And I think we've reversed our positions in
Absolutely.
some ways.
I think that the more I have heard the competent therapist voices, the more I began to respect your competence, Carl's competence, and begin to say, within my particular conceptualization, see, I don't change what is my goal. What I have developed is the freedom. I have at this point so many anecdoticals. I had seen thousands of families, and I had watched hundreds of therapists seeing hundreds of families. So one of the things that happened to me is that I don't see anew. In every situation, I had seen it before, 4, 5, 10, 15, 20 times. As a matter of fact, not only had I seen these families 20 times, I had seen 3, 4, 5, 10 therapists seeing the same family. And so that, I think, gives me a certain freedom to select and to be spontaneous, knowing that these voices help me. You know, I am saying these voices lead me. It is part of my experience.
There's another thing, too, though, if you think situationally, that I think you had a lot of ideas like that from other people when you were more focused on training people that you felt you had a large responsibility for getting them competent so they could deal with the people who need it. Now you're in a position where you can be more leisurely, where you're teaching a master class, where the people you're teaching, you can present different ideas about different therapies, whereas I'm still in a position where I'm focused on training a group of therapists in order to do a competent job. With the students that I have that are experienced, that I spend some time with, I have the same feeling of freedom you do, that when they talk about it, I say, well, it's also this way it's done and this way it's done, and you can take it from this point of view. With the ones I'm training in ABCs, I tend to go narrow, really.
But
within the breadth of
because I think that we need to teach at two levels. See, we need to develop teachers also. We are developing students, and we want to develop teachers so that they transcend us.
Sure.
And so it is at the point in which you're working with people that are competent, that you know, that you said, okay, look, let's begin to look at what other people do.
Because what you want to do is produce people who will do that which you wouldn't have thought of doing and do it successfully.
Yeah.
Not just what you already know. That's right.
See, the question is, how can we teach people to transcend us?
That's right.
So if I want to teach people to transcend me, then I will need to say, look, Jay does that.
There's other ideas besides mine you have to do in order to transcend you.
And they are pretty good. And they are done in competent ways. Not only that, but I had studied them, I had observed them. They are good. See, I teach only voices that I respect.
Sure.
And then people then begin to play around with many voices. I think it's important.
Well, I think they have to reach a certain level of competence before that doesn't just become confusing.
Yeah. I think that this is true. That means at which stages you introduce this level of complexity.
Because you need at a certain point to remind the trainee that they can do absolutely the opposite of what they're doing, and it can be successful if they do it in the right way. That there's such a variety of ways of working. Once they learn how to work, then they have the freedom to innovate.
You see, at the point in which we are teaching about the fact that there are a variety of ways of entry that are all competent, then we introduce questions about what is the process of change.
Sure.
Since a variety of ways of working with people is successful, we need to ask ourselves, what are the generic things that these different people manipulate in some way?
We also have to, first of all, be sure they're successful.
Oh.
Because there's a lot who aren't that have made a big issue in the field. But suppose a student is now stuck with a teacher who wants him to write a paper on the difference between strategic and structural therapy. What do you have to say that's going to guide that young person?
Well, I think that there are some things that I can say. I think that the structural ideas had to do really a lot with how families are. I think that I, as a person that was a developmentalist and very influenced by developmental ideas, when I began to think about family therapy, I started thinking how families are constructed. And so a number of the ideas that are the maps and so on really are ideas about how families tick what is the family dances, proximity, distance, and so on and so forth. Out of that, and then I think a lot of the structural approach have to do with descriptions of families, family developments, family transitions, proximity and distance subsystems, and things like that. Then I began to, out of that, I began to develop a series of interventions that were based on how to change proximity, distance, intensity, and so on, but that actually I think can be very different than the ones that I described. And I think that the strategic approach started with concentrates a lot in the how to change the families, and it paid less attention to the description of the family.
How you describe it, that's true.
And so I think that the differences had been differences on what were the areas of focus. You know, at this point, for instance, I am still very much involved in trying with Pat to look at normal families and to begin to elaborate, to make more sophisticated descriptions of how families are. That will not give us really new ways of intervening.
No, that's a different enterprise.
Yeah.
I used to test normal families and see the variety among them, and I didn't find it relevant to therapy. I found it interesting anthropologically. Let's try it this way. Can you think of a strategic trainee who came and presented something, hopefully somebody we trained, that was reasonably competent, who presented a view that you didn't agree with because of the training? Let me give it, the reason I bring this up is because I can think of one that came. I had a visitor from a structural center, two visitors, and there wasn't a family at that moment, and they said they wanted to see what we were doing. So I had a tape from a family the day before, a few days before, and I said, here's a tape, I think you'll enjoy it, thinking they would be interested in this. It was a tape of parents and a young man about 18 or 19, just coming out of the mental hospital, defined as schizophrenic, full of medication. And the parents bring in their sick son and define him as sick and coming out of the hospital and so on. The therapist, who was a woman, began to talk to them about what could their son do, what couldn't their son do, now that he was coming out of the hospital, ready for a fresh start and so on. And she began to redefine the problem as not an illness, but as a son who wasn't doing the things he should be doing. And that as he came down off the medication, would they expect him to go to work? And they said, it occurred to us he might go to work. He just graduated from high school or something. Mm-hmm. She said, I think you should begin to think about him going to work. I mean, why wouldn't he? He's 18 years old. The father said, well, I guess he should. Anyhow, it was that kind of an interview in which, in 1 hour, by the end of the interview, that case had been redefined from an illness to a son who was tending to malinger and really the parents should get him. And the father and mother said, we'll get this kid out this week and he'll start doing something. I was pleased with the session, and I thought these visitors would be pleased. They said they thought it was an awful session. And I said, why is it an awful session? We achieved, by the end of that interview, a therapeutic plan that was going to work, obviously, and get this kid on his feet. It was the only hope for the kid, really. They said, well, you didn't have any enactments. So I said, well, what's an enactment? And they said, an enactment is what you put them through that brings them out the structure of the family. I said, I was thinking of the kid getting on his feet and going to work and supporting himself. Now, that was a difference in terms of a strategic approach to this kid and something we weren't doing that apparently a structuralist would do.
Now, I think that this is the same thing that people that think that there should be a positive connotation, and if one challenges a person, then one says, well, you didn't have a positive connotation. I think that maybe this session was absolutely lousy, and the way in which you describe it is so perfectly okay that the only thing I can say is, if I would see that kind of session, I would say, I don't see that as particularly strategic or structural or anything that requires a label. I think that this is a situation in which you are organizing a family to function better.
Well, it's also
That
very,
would be
it's
the
similar
reaction.
to the way you would redefine an anorectic as not ill but disobedient.
Yeah.
It was the same principle,
No,
really.
I don't see,
It's a way of motivating the family to get the kid normal.
it is, I think that when the case that you described, it interests me. Because you see, enactment was a letter. It was never a word.
What do you mean, letter E?
Yes, E. It was the alphabet.
Ah, I see.
Intensity is a letter. It's not a word. So when people say this is wrong or right because it has or it doesn't have positive connotation, or you didn't do a circular questioning, or you did, it is people that are stuck at the alphabet thinking that these are
Well,
words.
there are people focused on the process of the therapy rather than going as quickly as possible to the outcome. Yeah.
And so it is an unfortunate. See, I think that it is because I know that there are people that could say, if this session didn't have an enactment, then it's not a good session, or if it doesn't have intensity, it's not. That I had moved in my teaching to begin to look for the appropriate ratio of theory and implementation, how to think and how to implement your thinking. And I look at students very much in terms of people that can be good implementers of lousy thinking. And then what do you do?
Sure. What I just had a thought, and I lost it. Well, here's the thought. Suppose, because you have an emphasis on process in therapy more than I do. Suppose you could take somebody, as I have, and get them over a symptom, and they had total amnesia for the therapy. All they knew is that they had the symptom and they were over the symptom. Would you be pleased with that outcome?
Well, you see, when you do follow-ups, then you find yourself very frequently that people don't remember what produced the change.
Oh, sure. They don't remember. They don't often remember how intense the symptom.
So that, but you see, the question is that I redefine the symptom in terms of the particular way in which people position themselves in relation to the symptom bearer. So the fact that the symptom can really disappear and be forgotten, that would not be an important consideration
But
to me.
that's different than feeling that if somebody got over it, I'll tell you a funny story. I'm not sure it's appropriate for the tape. There was a guy who came from New York, a patient came from New York, who'd been in analysis for 8-10 years. And his problem was that every time he went to urinate in the bathroom, he masturbated. So he masturbated many times a day. And he had been in analysis for years with this problem. And he moved to Philadelphia. And the analyst there referred him to psychiatrist B, who was uneasy dealing with this guy, with this difficult symptom, who had had so much analysis, and he still had the problem. So he asked to conjointly see the guy with psychiatrist A. He said, I'll see him 1 week, you see him the next week, and we'll work together to solve this problem. So he saw the guy, and the guy told him the problem. Then the guy went to psychiatrist A. And psychiatrist A said to him, after he described how he masturbates every time he goes to the bathroom, psychiatrist A said to him, I think you should stop that. Don't do that anymore. And the guy stopped it. He never did it again. Psychiatrist B said to psychiatrist A, how could you do a thing like that? Don't you realize that the man hasn't worked through anything behind the symptom? Psychiatrist A said he's had 7 years in analysis working through what's behind it. He doesn't do it anymore. It's a successful case. The other guy says it wasn't a successful case.
Yeah.
Now the question is, was it a successful case?
I am absolutely uninterested in that case. You see that I think it's an interesting issue, because the symptom per se, I work for the disappearance of the symptom as part of a larger constellation of issues. So certainly, if the symptom disappears and there is amnesia, I don't care.
But would you consider that a successful case?
Which one?
The guy who stopped masturbating?
I don't have the slightest idea.
I mean, he'd been doing it for years at the end. He
know,
was in therapy for that problem.
I think that probably the first thing that I said to the patient is, stop doing that. So that, but that would be just a natural thing. Why would you do a crazy thing like that?
That's different from telling him to stop.
If you want to urinate, go and urinate. If you want to masturbate, go and masturbate. Please don't do these two things together. I would stop that. But that would not tell me if it was right or wrong, because I am not thinking like that.
But here's what's interesting to me, is here you have a symptom of somebody, and over here you have them without the symptom. And in between, different schools of therapy do different things. Some they have to go through an understanding insightfully. Others have to go through a change in their behavioral manifestations and positive and negative behaviors. Others, they have to go through a change in the family structure, and then they get to this point where the symptom is. Or you can go absolutely directly and just get rid of the symptom.
You see, I think that I see it differently. And let me,
Well, that must be because you're a structuralist.
I hear that, yes. I don't think that a family produces a symptom necessarily. But I think that a family always maintains a symptom, when we are thinking. So that the origin sometimes is,
Sure.
It's different. The first thing that I do in the first in the first stages of therapy is to negotiate implicitly what are we working about. And in the first stages of therapy, we will have a redefinition of what is the symptom that will include the positioning of all family members around each other. That becomes to me the area in which I will try to produce change. Now, I never stop thinking that the symptom bearer needs to stop having the symptom. This is part of, okay, how do I do that?
So you would say if the therapy ended and the symptom bearer still had the symptom, the case would be a failure then?
Yes.
Even though the family structure had changed, they learned a lot?
I think that...
Well, we're in agreement on that.
Yeah,
because some people wouldn't
I would say that this is, that the change needs to include, certainly, a change on the symptom bearer symptom. But that this can be achieved. You know perfectly well that in the anorectic patients, we would achieve, certainly with young anorectics, they would begin to eat after 2-3 sessions. And so there you had a cessation of the symptom, and I would continue working with them.
Did you continue because you thought they would stop eating if you didn't?
No, because I didn't think that I had finished my work. I felt that the symptom was much larger than the not eating, and that the symptom that I wanted to work with the expanded symptom, that was the particular way in which this family is constraining this girl to explore different avenues of being. and other things like that.
Sure, I would agree with, I'm not in disagreement with that. Because I think there are times where just getting the girl started eating is a sign of a change in a family, and that change will continue without me.
Yeah.
There's other cases, the girl started eating, the not eating has been an indicator of a difficult problem which isn't resolved. And that I would still worry about, if not the girl, about the mother, say, or the father, and go on with it.
That's how I think.
Yeah.
That's how
And there's other symptoms where I just feel if you got rid of it, that's it. And that the family would survive and doesn't need further work.
I think that the difference is what we consider a symptom. See, I think that I am involved, like you, in changing a symptom. But I think I define a symptom differently.
I define a symptom as any behavior that the person says they can't help and that's inconvenient to others. A person who can't stop eating, or a person who can't eat, or can't stop bathing, or can't stop stealing, or whatever. When they say I can't help myself, I have to do this. That's my definition of a symptom.
Okay, and I would say that what I would define a symptom is this particular person plus the behavior of the other people that support him getting stuck in that position.
That such a person must have a helper in the family.
Yeah.
And they must have somebody objecting to the helper helping. That you have a structure that goes with that symptom.
Yeah.
But the question is, what
and
do you
I
have to
call
change
that the
it?
symptom.
Oh, I see.
I call that the symptom. You see.
Sure.
I really find, and I find a way of saying to the family, that is the symptom, and let's change it. Let's.
But would you say that to the family, that is the symptom? The involvement of the family in the symptom?
Oh, I do all kinds of things, so I don't know. At times I would, at times I wouldn't. At times I would work with them in such a way that they would say that, or they would say something else. But that enters.
I would assume they know that, and I wouldn't mention it, and be discourteous myself.
Well, you see, I could say, working with alcoholics, for instance, I would say to the alcoholic, how does she make you drink? Isn't that a curious thing?
You'd say that in her presence?
Yes. How does she make you drink? You know, so
I would assume that he would think that and she would think that, and I wouldn't say that. But I might encourage her to make her think.
No, you see, when I said, how does she make you drink? What will happen is that he will say, no, I drink.
Sometimes he'll say that, yeah.
And I would say, no, what are you talking?
Sure.
That certainly is not so. In my experience, she really is, and why does she do that? You know, it's a very curious thing. Why don't you talk with her about why would she do such a curious thing when she says she doesn't want? And it would go like that. And then there will be a dialogue, and I would...
You would really define for the family that our feelings are in each other's hands. That how I feel, if I want to feel in a certain way, I usually have to go find somebody to do something with so that I'll feel that way. That our feelings involve other people. And you make that explicit with the family.
And that they really are controlling. There is an illusion that you are drinking because you are drinking. It's very interesting that you have that fantasy.
Well, what's his name used to say, it takes 5 people to keep somebody drinking.
Yeah, yeah.
That it's a difficult symptom to maintain. Well, can we conclude now that anything anybody wants to know about the differences between strategic and structural therapy have been made evident?
Absolutely.